Hello, everybody. Welcome to the 19th Century Charitable Association, where it is our vision to be a dynamic cultural center for community learning. Good afternoon. I'm Susan Roberts. I'm the Science Program Chair. We have scheduled 29 programs this season in this Monday Enrichment Series as part of our mission to strengthen our community through learning, giving, and sharing our landmark building. The name of the program is No Pain, No Gain, KNOW. And I'm pleased to introduce our speaker, Sean McInerney. Sean is a certified physical therapist with his PT, DPT, and OCS credentials. His practice is called Elevate Physical Therapy and Fitness. Pain is a very complex human experience, which sometimes protects and other times limits us. What happens within our body when we experience pain, and how can long-lasting pain affect our nervous system and condition responses to pain? Dr. Sean McInerney will discuss these findings and how they are used in physical therapy to help people with pain. So welcome, Sean. Thank you.
Thank you, Susan. I appreciate that introduction. As Susan mentioned, my name is Dr. Sean McInerney. I will tell all of you a little bit more about myself in a bit here, but with the topic for today, we are talking about the idea of no pain, no gain. And I'm sure a lot of you have heard that expression before, maybe even said by a physical therapist before. But we are spelling that differently today, obviously. Usually, no pain, no gain being N-O, but today, K-N-O-W. So my goal for you today is that if everyone here just can learn a little bit about pain to help either yourself or maybe someone you know who is experiencing pain, because the idea here is that if we know more about why we hurt, then we are going to know how we can recover from that hurt. And so that's what we'll be talking through here today. But before going into more about that, I want to tell you all two stories. And collectively, we call these stories a tale of two nails. So I see some reactions already looking at these. And they're, these are true stories, okay? And so we'll start with the x-ray here. This picture was taken in 2005. A construction worker was on a job and using a nail gun. He fired that nail gun, and it sort of backfired and kind of ricocheted, and it did end up hitting him in the face. What was interesting, though, was that a nail did lodge itself in the wood near where he was intending it to go. So he had the nail gun go off, it hit him in the face, and he felt a bit of a toothache. He felt a toothache, and he didn't do anything about it for 3 or 4 days because it wasn't really that bad. It was just a toothache. He figured maybe that nail gun hit him in a way that upset a tooth or something. He ends up going to see a dentist who then took an x-ray and found this picture that he had a nail lodged into his skull very close to his brain. So he had a near life-threatening injury and felt almost nothing more than a toothache that he didn't even have to take care of for a number of days. So that's one story. Let's put that one aside for a second. Let's go to the second nail. And this picture here shows what happened, the boot. An individual, this was in 1995. This is a carpenter. He jumped off of a platform and landed on a nail, and that nail came through to the other side of the boot. Now I see again some reactions. We'll talk about that. You guys are actually experiencing pain right now, hearing the story of somebody else. Pain is complex, right? As Susan mentioned, pain is complex. You all are feeling that already. But here's the interesting thing about this story. He was in so much pain, writhing in pain, he went to the ER. He asked the doctors, please give me something before you take that boot off and get the nail off. I'm in so much pain. So they did. The doctors did. They got the nail out. They got his boot out. Guess what? The nail went right in between his toes. He had nothing more than a little scratch. So we have two stories here, right? And they're opposites. We have one individual near life-threatening injury. This nail came close to his brain on the left here. And guess what? Nothing more than a toothache. Didn't even need to do anything about it for a few days. And then we have the other individual who had no injury. I should rephrase, a very minor injury, a minor scratch, and he was in immense amounts of pain. So I'm going to say it again. Pain is complex, right? Pain is complex. So that's what we're here to talk about today. We're going to come back to these stories a few times throughout my presentation. So you'll remember them. They're kind of interesting, but we'll talk more about why that might be. So first, who am I? During lunch, I got a couple great questions about what are all those letters after your name, and what, are you a PhD? Are you a doctor? So I am a doctor of physical therapy. So a lot of you astutely knew that physical therapists now are required to have a doctoral degree. That's the entry-level degree now. But I'm not a physician, and I'm also not a PhD. So I have a DPT, so that's some of the letters. And then OCS is after my name as well. That stands for Orthopedic Clinical Specialist. So I'm a clinician. I don't do research. I work with patients. So what does my day consist of? Seeing patients, the vast majority of who are in pain. So I'm not a researcher. So while I do talk about studies and evidence, my main focus here today is to help you understand how this information could help you with real life situations. My practice is in River Forest. We're on North Avenue, Elevate Physical Therapy and Fitness, and I've been working with patients for 10 years now. So that's who I am. That's my background, and we'll continue on here. So when we talk about pain, we need to talk about the nervous system and just make sure that we're on the same page when it comes to some of the terms we'll talk about. So I hope this is review for a lot of you, maybe new for others, and that's okay too. So with the nervous system, we're talking about everything from the brain all the way to the tips of every single toe, down to the tips of every single finger. Every single part of the body has nerves that are going to it. And so the brain is our headquarters, right? That's where we process and everything. All the information comes in, and then all the directions go out. And then the brain connects to the spinal cord, which then branches off into many, many different branches, all the way to all those different body parts. Now, to look at a cell individually, we're looking at a nerve cell in the middle here. What this nerve cell does is it carries messages throughout the body using electrical signals. So on one end of the nerve cell, information comes in. If it's sufficient enough in information, then that nerve cell passes that information down the path into the branches at the end, at the south end of this photo. And so when a neuron gets a signal, it sends an electrical impulse down the nerve, and it either goes to other nerves, it might go to muscles, sometimes glands, sometimes it's information coming from the skin, sending back up towards the brain. So it's a communication pathway. Now, with the nervous system and the brain, it is working 24/7 hours a day, every single day at all times. The brain has to then decide what to do with that information, and then also decide what sort of actions need to be taken based on that information. Now, the really cool part is this is happening all the time, and often we don't have to think about it. So some of you may have noticed there's a t-shirt on the slide here. And so before I start to talk about it, I hope that none of you are very aware of the fact that your clothes are touching your skin. The clothes are always giving the information to our skin, right? And the skin is then sending that message to the brain. The brain then does a really great job of saying, that's not important right now, right? My t-shirt's not a threat to me. My pants aren't either. So the brain just kind of says, okay, but I don't need to be aware of that. Now that we're talking about it, you all can, if you move a little bit, right, you can feel the way that the shirt is touching your skin. That's happening all the time. And then the brain just needs to decide what to bring to more of those frontal cortex, so that being the higher level thinking type things. So that's in a gist, is what's happening with our nervous system. But then it also is happening when we get to the idea of pain. So with pain, well, why do we have to experience pain, right? Like, what a terrible thing for us to have to deal with. Well, in reality, it's actually a good thing. Now, I don't start off my sessions that way, right? If someone comes in and says, I'm in pain, I say, good, that's awesome. That usually doesn't go over well, but we need pain. Pain is our way of our bodies getting our attention. So we think of that as a primitive form of protection. So I've got 2 young boys at home, and they're learning about this, right? One of them just yesterday, he's standing, he's helping me cook, he's on his little stool at the counter, and he brushes his hand against the crock pot. Now the crock pot had been on, it was hot, it didn't damage him, but what did it do? It got his attention, right? It got him to pull his hand away from the crock pot. And he got some kisses from Dad, and he was all good, and we were on our way. But think about if he didn't have that pathway. If he didn't have pain, he might have left his hand there longer, and he might have then experienced some serious damage. There's actually some times that people have lived this way, where they were born without the ability to feel pain. It's not a good thing. They would really injure themselves before they would actually be aware of it. To take that same situation of a burn, there was one woman, she didn't know she had this inability to feel pain. She didn't know she was being burned by something until she smelt it. And think about how horrific that is, right? She had to smell her own skin burning before she knew that there was damage there. So this is the case of why pain is a good thing. We need it to protect us. Now, what we've learned is that as human beings that are highly developed creatures, that isn't always a direct function of pain and damage. And we'll talk more about that. The reason is because we have two elements of pain here. And I want you to think back on the last slide when I was talking about the nervous system and how the brain is the headquarters. We have information coming into the brain and then the brain deciding what to do about that information. Think about the t-shirt again, right? So what we call the process in which information sending about harmful stimuli to the brain is nociception. So the definition that someone else wrote that I will not take credit for, so it's in quotes there, the neural processes of encoding and processing harmful stimuli. It's an input to the brain is the key point here. Versus if we talk about what pain is the brain's interpretation of that information. You can think of it as the brain's guesstimate as to how much damage there is or how much threat level there is. So let's go back to, for the first time, let's go back to our 2 nails, right? And the individual who had the nail gun. Remember what I told you. He shot a nail gun and he saw a nail go into the wood close to where he intended it to do. Now, he didn't realize that a second nail had been fired too. But if you've ever used a nail gun, and it's meant, some nail guns fire multiple, but this one was meant to fire one. He fired one, he saw it lodged. He knew he whacked himself, but why, in any reason, based on those clues, would he have thought that a second nail had gone into a skull? It just doesn't make sense, right? So he maybe just processed that as a toothache. So his brain interpreted the information that he had and said, there's not a high level of threat here. He was wrong, but that was the case. Now we take that other individual, and we all kind of had a chuckle, right? He was writhing in pain, but there was no real injury other than a scrape to his toes, the individual with the boot, right? But I think any of us in that situation, if you saw a nail coming through from the bottom of your foot to the top, you would feel pain. In fact, I saw a lot of the faces here just looking at the picture. You all felt pain just looking at that. And so the brain interprets that information and decides what to do on it. So what we can be clear on here is that the nociception, which is the input to the brain, is very different than what the brain then decides to do about it. So input versus output. So those were 2 stories, right? They're just one person. They were true stories, but they were just one person. It's interesting, but what does the research say about that? And when we do this as an actual study, what do we say? So pain can it be affected by contextual factors? There's a variety of studies on this, but a few that I wanted to highlight were studies that looked at how pain was affected based on different factors. So the first one is colors. I have these lights here, the red and the blue. And in this study, what they did is they exposed people to a shock. Now, it was not going to be a shock that injured them or damaged them, but it was just a shock. And they asked those people to determine how painful that was. The interesting thing is that if people were exposed to a red light at the same time as they received that shock, they were likely to say it was more painful than if they were exposed to a blue light that was giving the exact same type of shock. So we know colors. Colors can influence things. Red is known to be a color that sort of heightens us, alarms us, versus blue, a calming color. The other studies that have been done, one looked at model placebo. I'm sure some of you have heard the term placebo before, but a placebo can be any sort of harmless pill or procedure that's prescribed more for the psychological benefit than any other physiological effect. So these studies are pretty common where they'll compare a pill to placebo. So the pill actually has the active ingredient, where the placebo is just a sugar pill. It's just the act of taking something, and it's a better study when they compare something to placebo. But what is a model placebo? Well, a model placebo is somebody else. So in this study, what they did is they had people receive, again, an electrical shock. But before they received it, they watched somebody else get the same shock. Now, what the study participants did not know was that the person ahead of them was in on it. They were part of the research. And that person would say, oh, no, that wasn't too bad. That didn't hurt that bad. If they saw somebody else say that it didn't hurt too bad, the study participant then also said it doesn't hurt too bad. So that's another way that pain can be affected by contextual factors. So we have colors, we have other people, and then virtual reality. So virtual reality, I'm sure some of you have seen it. It's those headsets, right? And it's very immersive. It's your entire visual field. It can vary from things where you're just watching a peaceful scene, such as a beach or a park, but it can also be games where you're interacting with that virtual reality. So in this study, what they did is they had individuals who were receiving treatment for burns undergo virtual reality as they were receiving that treatment. And so if any medical providers are out there, they might know that burns are something that are said to be one of the most painful things to undergo and then to have the treatment for. Now, of course, when they're doing these sorts of treatments, they give individuals opioids and other ways of managing their pain. But they found that if individuals were in a virtual reality headset at the same time as receiving treatment from the burns, that they had less pain. So again, looking at something different in a different sort of virtual reality can help with pain. So between the two stories that we started off today with the two nails, and then also these various contextual factors that can alter pain, what I'm trying to make the case for is that pain does not always equal tissue damage, okay? We can have scenarios with high tissue damage and very little pain, and we can have the opposite, where we have high amounts of pain with very little tissue damage. And the reason that is again, that pain is the output from the brain that is the interpretation of the information. It's the brain's guesstimate of how much damage there is. So that is kind of the what, but let's talk about the why. Why does this happen? And so there's a term that we use to describe any sort of changes that can occur to the brain, and that's called neuroplasticity. So for those who maybe haven't heard this term before, let's break it down. Neuro, so that refers to nerve. So when we see neuro, we're talking about nerves. And then plasticity, so plastics in there, right? Change, that's what plastic can mean. So it's the ability of the brain and the nervous system to change. And again, the definition that someone else came up with that I think is really good is a process that involves adaptive, structural, and functional changes to the brain. So I really like this blue picture here because it's showing a brain as a construction site, right? Our brain is constantly under construction. Yours are right now if you're listening to what I'm saying, right? You're taking in information and the brain is adapting because of that. Another picture on here is an individual learning how to type. If anyone remembers when they maybe learned how to type, it's a very cognitive task, right? Eyes are looking at the keyboard, maybe one finger at a time, right? Learning how to type. If you do that enough and practice getting better at it, you can do it without thinking. You can use multiple fingers. You get faster. The brain and the nerves that correspond to the fingers actually got better at doing that task. They adapted, they changed. So that's called neuroplasticity. And I put in here, it's mostly a good thing, right? We want to adapt to what we need to do. That's important. However, in the scenario of pain, we can see where that can be a bad thing. Now, what happens in these scenarios is that the brain and the nerves, unfortunately, become better at pain, which really isn't something that a lot of people want to become better at, right? So it's mostly a good thing that our brains are adaptable, but sometimes it can lead us to a little bit of trouble. So why does it change? So this is called a homunculus. And so what I want you all to picture is if that my hand here came straight through my skull and I was able to look forward and backwards. That's what we're looking at right now. We're looking at the lobes of the brain, and we call this a homunculus. And what it is it's showing what part of the brain corresponds with each body part. So if you look at, on the blue side here, you can see that the tongue is really big, the lips and the face are really big, the hand is big, but then look, forearm, elbow, neck, hip, knee, much smaller areas of the brain that are occupied by those spots. So why is that? Why do we have not representation of just the physical space? Well, it comes down to evolution, right? How do we survive? Well, we need to know what we're taking in our mouth, right? We need to be able to manipulate food. That's important for survival. And so is using our hands. That's how we grasp, interact with the world. So that's called a homunculus. It's our body's regional map of it's our brain's regional map of our body. And so with a homunculus of somebody who is in chronic pain, meaning pain for a long period of time, they've actually shown that this map becomes altered. So for example, back pain, super common. Hip pain, knee pain, all those different things, very common. But let's say that it is back pain. The area of the brain that corresponds with the back actually becomes changed. Neuroplasticity, right? We talked about how the nerves in the brain change. And so the brain actually changes in response to that pain, and it becomes altered. Sometimes smudgy is the term that's used. What it means is that the brain has a little bit harder time interpreting information coming from that area, but also sending information to that area. So when I say coming from that area, I'm talking about sensation, right? For example, if one of my clients who has back pain that's been going on for a long time, I might just touch their back and they report a high level of pain. Now, cognitively, they know I didn't damage them. They know that they didn't get threatened or injured there. But they also know that true pain is being experienced from just something like touch. And so that's because the homunculus can be altered. Now let's take the brain's other role. It's meant to send information out to the body. I might tell someone, okay, I want you to try this exercise for your back. I want you to try bending it or moving it this way. And they might have a really hard time doing that. They might see me do it and say, okay, it looks good when you do it, but I can't do it myself. I can't make myself move that way. And that's because the brain changes in response to long-lasting pain. So with that, there's a term we use, it's called sensitization. So the definition, as nociception, that input and pain persist, neuronal mechanisms involved in both become more sensitive, which means that the relationship between pain and the state of the tissues becomes weaker and less predictable. Again, coming back to the idea that pain is not always the best representation of tissue damage, especially in longer lasting pain. So with that, we've talked about the term, but I would like to define it, of chronic pain. So chronic pain defined as a wide range of persistent discomfort lasting beyond 3 to 6 months and often originates from various sources, including injury, disease, and here's the key here, unknown causes. So chronic pain is simply just pain that's been long lasting. But what happens when we're in chronic pain is that unfortunately individuals get stuck into this chronic pain cycle. So this is a cycle, so it's sort of continuous, but where I'd like to start, where we talk about it here, is in that upper right corner, the blue arrow, and it says there, injury or flare-up of pain. So this is usually how it starts. There's some sort of true injury that is a painful event, but then it becomes more than that. An individual might be afraid to move after having this injury. They're afraid that they maybe will hurt more, or it might hurt more. They might feel more pain when they try to move. So naturally, what's somebody going to do? Well, they're going to stop moving. They might avoid activity if it gets to a certain level. Then they might not be participating in social events, might not go to work anymore, might not see their loved ones or their family or friends. And therefore, then, they're becoming socially isolated and losing more and more activity. Anybody who maybe has experienced social isolation before knows that that can come along then with depression, anxiety, and maybe then even more fear of movement. So now we've gone around the circle, and we can see how then maybe we then feel more pain, or we have a flare-up of the existing pain. And then unfortunately, it just feeds into itself. So this is where people can oftentimes get stuck with chronic pain. And so with chronic pain, there's some terms that I like to talk about. They're science-y definitions, but the three terms here, the first being allodynia. So someone in chronic pain might experience this, and what it means is that not just painful stimulus to the skin or to the body cause pain, everything causes pain. So somebody might, I might touch somebody's low back, or I might touch their shoulder after an injury, and just that mere touch is enough to cause pain. Now, that is a little different than hyperalgesia. Hyperalgesia is when we have something that already was painful, but somebody who's experiencing chronic pain might experience that as even more painful, right? So something just like maybe a small paper cut, or bumped, a bruise or something might feel extremely painful to somebody who's been dealing with pain for a long period of time. And then central sensitization is another term here. That central part of it, what that means is that not only the area that was initially injured or the area that's painful starts to change, but centrally it starts to change too. So the brain, the spinal cord, all these things can change when someone's been in pain for a long period of time. So we talked at the beginning, pain is very complex. I don't claim to know everything about pain. In fact, let me rephrase. In fact, nobody knows everything about pain. We're still studying it. There's great researchers out there who are looking into these sorts of things. So when we are talking with somebody who maybe is experiencing pain, sometimes some analogies or different ways of thinking about it can be really helpful. One that I like that I did not come up with from a group called the NOI group is the Twin Peaks model of pain. So with the Twin Peaks, we got two mountains here, and I want you guys to focus on the one on the left. At the bottom there it says pre-injury. So with pre-injury, I want you all to picture as if you were doing a really grueling hike, or maybe even climbing up a mountain. And when you're going up that mountain, pushing your body and pushing what it's capable of doing, you're going to start to feel some stuff, right? Anyone who's ever done any sort of endurance activity knows that. It's not fun for the moment, right? It hurts. So your body is giving you a pain warning. It's saying, hey, this is challenging. You're really pushing the limits here. But a lot of people, we keep going, right? And we keep hiking up that mountain, and we're going up higher, or we're going up steeper, or maybe into an area where there's less oxygen. And so after that pain warning, what we reach is a point where there's a limited tissue tolerance. So after you get past that tissue tolerance point, you're really risking some injury for yourself. And so with that tissue tolerance, beyond that point, again, is when injury can occur, and let's say that it does. So now we're on to the second mountain here, and we've come back from an injury, we've gotten clearance, and we're saying, okay, I'm going to try that same task again. Now what I want you to notice here on that second mountain is that the lines are in different places, right? As I'm going up that mountain, the new pain warning comes on much sooner. It's coming on much sooner for a few reasons. One being that after an injury, I probably haven't done that activity again, right? So the body is saying, hey, this is something that we're not as accustomed to, we're not as built up for. But also, the body is going to become more protective because it doesn't want to experience that same pain injury again. So not only is that new pain warning earlier, but then there's also a greater gap between when that pain warning comes on and when that tissue tolerance point comes. So the body has become more protective after that injury. Now notice too, that tissue tolerance line is lower. And that's what we talked about before, that if we haven't been doing a certain activity, we're less conditioned for it, we're less able to do that. So that's what can happen after an injury. And it's a nice way to sort of visualize not only the physiological changes that occur after an injury, but also how the brain changes in response to that injury. There's a great story from a researcher, if any of you are into TED Talks, but he tells a story about he was walking through a forest and he felt a little scratch on his ankle and he didn't really think much of it. He kept walking, he finished his hike, and it wasn't until he stopped, he looked down and his ankle had swollen up. It turned out he had a couple marks on his skin. He had got bitten by a snake. He got treated, he got it taken care of, and he was okay. But guess what? Next time that he was walking through that same forest, he felt a scratch, and what did he do? All of the alarms went off. He freaked out. His body put him through that same sort of sensation to protect him. He looked down, and it was just a stick. He had just a scratch. It wasn't a snake again. But that's a real example of how this can happen with the Twin Peaks model of pain. So any TED Talk people, he's pretty funny and tells it really well. So after an injury, there's a few other things that can occur that can lead us to become into that vicious cycle of chronic pain. So one of them is catastrophization. So I have an injury here, an ankle injury. It's really, really common. They can go a few different ways, but most of the time, ankle injuries, once the swelling goes down and once an individual is able to walk and come back after that injury, like a sprain or something, they can recover really well and get back to most activity. So that's one path that you could take. But another path could be that during that recovery, you rest and you recover. You're resting, you're recovering, but you might start thinking, ooh, this is going to be bad. I'll never really be able to walk again. This is really going to be something. And that's catastrophization, right? Catastrophe is the root word there. And so that is what can happen. The fear can make the pain worse. It can delay recovery and then make the person less likely to get back to normal activities. So catastrophization is one. Another one is fear avoidance, kind of along the same lines, but that's pain-related fear of activity. And so with this, I'm not expecting you all to see the text here on this questionnaire, but it's just a questionnaire that can be used for people to know if they are avoiding activity. So certain things that might be asked on this was that physical activity makes my pain worse, and then somebody would say if they completely disagree all the way to completely agree, or I should not do physical activities, which might make my pain worse. When talking about pain, it's really hard to talk about pain without talking about imaging. And so imaging, just to clarify, that can be anything from an X-ray to an MRI to a CT scan, any sort of image looking within the body. And before we talk about these studies, I just want to clarify, imaging is an amazing thing. It's literally looking inside the body. It's really incredible. It's an extremely useful diagnostic tool, and we need it, and there's definitely use for it. However, with imaging in relation to non-medically urgent pain, so for example, when I say non-medically urgent, I mean somebody didn't just have a recent car accident. They didn't recently break a bone, those sorts of things. There's evidence that imaging can be a little bit more harm than good. And to kind of highlight why that is, in this first study that I have here, 3,000 pain-free, so don't forget that part, 3,000 pain-free individuals had imaging performed, and the prevalence of disc degeneration increased with age from 30% of 20-year-olds to 96% of 80-year-olds. And remember, all of them pain-free. Now, disc degeneration, that's with the spine, that's a really common finding on an image. But if something's found in 96% of 80-year-olds, is that an abnormal finding? No, it's quite normal, right? If you're with the 96%, that's a normal finding. And so with that, there actually are some radiologists I've seen as of late who are writing these sort of statistics on their radiology reports. Radiologists, what their job is and what they do a great job of is describing what an image shows. They need to describe everything. So they'll write on there, this incidence of this finding in your age group or something like that. They might also say, correlate findings with what you feel or correlate findings with your provider. Because a radiologist is just looking at that image. They might have a little bit of background, but they're giving everything that they see on there. Second study to highlight here is that people who received early MRI imaging for low back pain had longer recovery times. So early MRI imaging, meaning within a couple weeks of an episode of low back pain. And keep in mind, low back pain, this is nothing that we're seriously worried about any sort of medical involvement. So we're talking kind of just orthopedic low back pain. But if you got an early MRI, that could be longer recovery times. So why is that? Why could it be longer recovery times? Well, if we know that abnormal findings, abnormal, right? Air quotes there. If those come up in quite a vast majority of pain-free individuals, well, imagine now you see that and you're in pain and how that might affect the psyche, right? You've started to think, okay, this is wrong with me. Maybe now I shouldn't move. I shouldn't do certain activities. I should stop doing that because it might make that worse. It can really kind of affect people and then lead to their recovery times. So an analogy I like is that some of these findings that we see on images are simply just gray hair on the inside. So the majority of us accept that we'll get gray hair as we get older. Some people get it young, some people don't get it at all. But the majority of us are going to get gray hair, and then we're also maybe going to get wrinkles. And so some people, like I said, have these earlier in life, others later in life. It doesn't mean anything's wrong with us or broken. It's just part of being part of the human species, And similar to gray hair and wrinkles seen on the outside, our body can sometimes demonstrate these changes on the inside. So just another way of thinking about it, an analogy. So what do we do with all this information, right? It's important to know about why pain might occur, why chronic pain might occur, but the important thing here is what do we do about it? And so my job, as a physical therapist is to use the tools that we as physical therapists have to help people, and one of those is education, and so talking about these sorts of things. So with the biopsychosocial model of pain, what this is here is it's a new way of thinking about pain that we might experience. To highlight the difference between this and the old school model of pain, the old school model of pain was simply just biology, right? If I have an injury and it hurts me here, there must be something wrong with me here. It's looking at the physical health, it's looking at genetics, arthritis, those different things, but it must be here. What this newer school model of pain does is it looks at the biology, but also recognizes that things like psychology and social elements of pain can alter how much we feel or don't feel. So psychology, we're talking about maybe some element of anxiety related to the pain, or depression, coping skills, self-esteem, mental health. Socially, we're talking about maybe how that pain influences family relationships or how other people around us talk about pain. So if we come back to our two stories here, the tale of two nails, let's talk about that individual who had the nail gun and a nail into his skull, felt very little pain, nothing more than a toothache, saw a dentist. With that individual, he had a very involved biological injury, right? Near life-threatening and really, centimeters away from his brain. But perhaps because of different psychological or social elements, that injury did not present as threatening to him. Contrast that with the individual who jumped onto the nail and saw a nail coming through his boot. Now, we don't know much about this individual, but I have to say one thing that I would think about pretty quickly is if I was in a field with manual labor and I saw an injury to my foot, I might start wondering about if I'm going to be able to work, if I'm going to be able to provide for my family. And think about now if I see an injury, how much more heightened that injury and my attention to that injury are going to be because of worry about that. So that could be the social element of things as well, thinking about how an injury might affect us, but maybe this individual, he knew somebody else who had a similar injury, and he knew, he was out of work, or he had a really long and complicated recovery. All those things are going to be part of what the brain puts into its determination to determine the level of pain. So with physical therapy, we are using the tools that we're using tools in order to help people to approach chronic pain. So this is a list. We'll go through it here. But education is really important for individuals with chronic pain. We are trying to talk about why they hurt and coming back to that idea of no pain, no gain, of course, spelling that K-N-O-W. But also, beyond education, which you all have experienced quite a bit of here today, the other tools that maybe are more associated with physical therapy are absolutely included in any sort of approach to chronic pain. So you notice I haven't talked to you about any specific exercises to do with physical therapy for chronic pain. I could not say that. It would be totally different depending on you and your level of pain and that sort of thing. But of course, exercise is one of the best tools that we have for helping with chronic pain. And what does the research say on that? Well, it says that with exercise for chronic pain, individuals feel improved pain levels, improved sleep, improved overall health with lower fatigue. So when I read that list, sign me up, right? Less pain, better sleep, better health, and feeling more energized throughout the day. That all sounds great. And we know that exercise can be effective for everybody for those things, but definitely individuals with chronic pain. The American College of Sports Medicine gives guidelines that the CDC agrees with, and this is for healthy adults. So 150 minutes of moderate intensity aerobic activity every week, in addition to 2 times per week of muscle strengthening activities for all the major muscle groups. And this is really the minimum. This is the minimum, 150 minutes per week, 2 times a week of strengthening. So every single person that comes in with long-lasting pain, we are talking through these, because what do we know about exercise? If anybody out there maybe is a endurance athlete or has run some long events, they know the effect of endorphins, right? That good feeling that you get. And we know that we can harness those sorts of things for individuals who are dealing with pain. There's a quote out there that exercise is medicine. And that's because there's a lot of research to say that exercise can be as effective, if not more effective, for managing pain as medicine. The only side effects of exercise are good ones too. Now, exercise is very injury specific. I can't say that there's a program for someone with back pain or a program for someone with shoulder pain. It's very variable and depends on how long you've had the pain, how intense it is, and what sort of rate of progression the injury allows us to do. Now, also on the list here is manual therapy. Manual therapy refers to any sort of hands-on work. So some people call it massage, some people call it joint manipulations, adjustments, those sorts of things. So those are hands-on techniques that we know are beneficial for individuals who are dealing with long-lasting pain. Beyond those sorts of things that we associate with more traditional physical therapy, we also are looking at things like goal setting. So what do you want to be able to do? what really is motivating you to get better. And so a lot of times those sorts of goals are social goals, right? I want to be able to do this with my partner. I want to be able to do this with my children or grandchildren. I want to be able to get up a flight of stairs so I can go to this event, those sorts of things. So we work on goal setting. So that's not just something the physical therapist sets for an individual, it's a team effort that we're coming up with goals. Graded exposure, that is something that is used for movement, but I put a picture of a spider on here because it's something that also can be used for phobias. Now, I intentionally did not put a photo of a real spider on here because some people, that can be very alarming. I see, yes, me. So you're welcome. No real spider on here because even seeing a photo of somebody, seeing a photo of a spider can be fearful for certain people. And so with the idea of graded exposure for a fear, it's gradually exposing to that. And so for example, maybe it's a toy spider first, and then it's a picture of a real spider, and then a video of a real spider, and to the point where you're gradually exposing yourself, where at the end of some of these studies, they have people hold the spider. And so I see some, yeah, right? But that is the idea of graded exposure. It's over weeks and weeks and weeks, right? It depends on the individual. But we're doing that exact same thing with movement. So a really common thing, I don't want to bend over to pick something up because I'm afraid that that will hurt me, or I know that that will hurt me. And that's very common. So what do we do about that? Well, you don't want to bend, and I respect that. I'm not going to force you to bend. But how about we work on a little bit of moving your spine while you're lying down in a similar way to what your spine is going to have to do when you're standing. Oh, you don't want to even do that? That's okay. How about I move your spine for you? And we'll start with that. So we meet everybody where they're at and then gradually expose them to something that they want to get better at. So that's the term graded exposure. Final two things here. Lifestyle education. So with chronic pain, if experiencing chronic pain, we need to get so good at all of the things that we can control, right? We can't control how much pain we're in, but we can control what we eat. We can control the quality of our sleep. Stress levels, a little harder to control, right? But we can set up some good habits to start to manage those. Talk to somebody if necessary. And then vices. I always put this on here. Vices, whether that's alcohol, smoking, those sorts of things, it's just another thing for the body to deal with, right? And so if we're dealing with an injury, we're dealing with pain, and now we're taking in some other sort of inflammatory thing, that's going to just be another thing for the body to deal with. So we're talking about those things. And that's setting goals on those sorts of things as well, too. And then I always have to highlight here, a physical therapist is not only, a physical therapist is not the only person who should be helping you in chronic pain. It should be part of a healthcare team, physicians, a psychiatrist, a talk therapist. Depending on your specific injury, there could be more. And so that's really important to recognize, is that it's a long battle and it needs a lot of people involved in that. So I think that I'm doing okay on time here. And so I want to open it up to you all for questions. And I'll let Susan sort of tell me what's the best way that you all do that.
What do you think of the expression, no pain, no gain?
N-O? Spelled N-O? N-O, yeah. So the expression, no pain, no gain, used in its traditional sense, has a time and a place. It's an interesting expression. I can't say that I am one that uses it outwardly with my patients. But with that expression, if it is in the sense of somebody saying that in order to change their body physically, they need to experience some discomfort in order to do so. Yeah, I think you said do enough exercise, that sort of thing. I think that is true. Anybody who's done a progressive exercise program knows that if it's comfortable, you're probably not changing something, right? But in the scenario where somebody is then recovering from chronic pain or an injury, we don't want to stubbornly push through pain when our body is giving us mechanisms through the nerves to say that we are in pain, right? So if you think about pain is there from a protection standpoint. So even in a scenario where pain is not correlated with tissue injury, if we are pushing through that pain, we're sort of feeding back into those mechanisms. And so there's kind of the right amount, if that makes sense, and it just has to do with each individual. And that's why it's really important that individuals are working with someone in a one-on-one fashion, somebody who's there with you every second of a movement or an exercise, and not on the other side of a gym with somebody else and kind of looking at you. So just kind of having somebody on your team to help make those decisions, because it's not easy and it's not a concrete science. So
I have a friend who has chronic pain syndrome and has 2 stimulators. Can you explain a little bit about how those stimulators work?
Yeah, so I'll start off by saying that I'm not the expert on what a stimulator does. The stimulators can be used in an effort to do a couple things. There's certain stimulators that might provide some sort of sensation in order to mask the pain so they feel something else. There's other people that feel a stimulator to sort of, or use a stimulator to sort of block a pain message that might be coming from them. But again, that's not as much my area of expertise, but there is, they're like what do they call themselves? A pain medicine doctor, is usually the ones that are working with those. Yeah. So,
I'd like to know what the difference between dry needling and acupuncture is, and what you would do for what.
Yeah. So I'll give you my honest, unguarded response. I don't think there is much of a difference. I think that people, including physical therapists, not myself, but people who want to do some form of acupuncture without going through like all the credentialing and licensing that's required to become an acupuncturist, can go a different route and do what's called dry needling. My understanding, although I don't do it with dry needling, I don't know acupuncture as well, although I think they're quite similar. The goal of any sort of like needle is to get a muscle response. So the needle goes into the muscle to get a bit of a response there. So in my opinion, not a whole lot of a difference. Maybe the philosophy behind it is a bit different, but physical therapists do dry needling, and acupuncturists would be this person doing acupuncture, but both involving needles into muscles.
As a therapist, do you look at the MRI images yourself to treat somebody for back problem?
Yeah, really good question. If I can, is my answer. If I can, because with my practice, we are not associated with any hospital system, so we don't often have the images easily accessible through an Epic or something, because we're a standalone facility. Now, if somebody brings their disc or has screenshots of those images, yes, I would take a look at those for sure. The thing that I like to look at, though, is the report that the radiologist gave. I always read through that because radiologists have so much training and expertise in looking at those images, where as physical therapists, that's not where all our training is. I mean, I don't know off the top of my head how long a radiology residency and fellowship are, but it's magnitudes higher than physical therapists. So if available, I'll look at it, and then definitely looking at the report and reading what the radiologist described that they found in the image. Yeah. Go ahead, question?
Speaking of images, the first image the radiograph that you showed, the guy who got the nail in his head, it sticks with me. And I wonder, how come he didn't bleed?
Yeah, so there may have been some bleeding, because he did say that the nail gun sort of like ricocheted into his mouth. And so there was some sort of contact there. But why was it not the extent of bleeding that should have occurred with a brain injury, like the highly vascular structure that it is? I don't know. Unfortunately, like like I said, a true story, but it's not like it's been, like a documentary style descriptions of it. It's just sort of news articles and that sort of thing, and obviously medical journals as well. But really good question, yeah. And maybe if he did have the bleeding, then that would have gotten his attention a bit more, or maybe just based on where it landed, it might not have hit a very vascular center. But that's a great question.
I'd like to know why did you decide to become a physical therapist?
Oh.
What was your point?
Yeah, thanks for that question. My story is not unique to me as a physical therapist. It's probably the most common story you'll hear if you ask any physical therapist that question. But I had physical therapy myself. I had knee pain as a runner in high school, and to be quite honest with you, my mother, if she were here, would take a lot of credit for it, because she was like, Sean, you'd be good at that. And I was like a 16-year-old boy, and I just said, sure. And I listened to my mother, and she said, let's apply to these schools. And I like it. I got lucky in that aspect that it's something that I enjoy doing. And to me, it's the right amount of medicine, right? I am involved in medicine, but not more than I would want to be. So that's the answer. So that's a very common answer amongst physical therapists, is they'll say that they underwent it themselves. And there's a lot of perks of a job of being able to move and at the end of the day help people, right? Which was something I didn't realize that was not true of all jobs. At the end of the day, I feel that I help people, and that's a good feeling. So I enjoy that element of it. But
why is it that some people are having pain, and you think, why are they not responding in a more difficult fashion than what that you couldn't tolerate? What it was that individual is going through? Yeah.
So it's a really good question, coming down to the idea of like pain is complex, right? It is. Not everybody can, let me rephrase it. The same injury can affect all of us very differently. And if it's somebody who maybe you think should be in more pain than they are, I would ask them what their secret is. Maybe they just don't want to outwardly express it, or maybe they, have come up with ways to keep themselves healthy in other ways, So it's hard to know without specifics on that.
What is the connection between barometric pressure and body pain, and what mechanisms might be in play there?
Yeah, so with barometric pressure, it's a really common thing that folks with arthritis especially will notice, that with changes in barometric pressure that they're going to experience more joint-based symptoms. What it comes down to is that there is fluid within all of our joints, and fluid then can be affected by pressure in the air. So it's kind of, even though that is something that is widely described, it's maybe not fully understood, because everybody's a little different on that. Some people feel the weather changes before they happen, some people feel them as they happen, and some people after the fact. But there is some truth just from population descriptions that barometric pressure can affect especially arthritic joints. So.
Thank you very much, Sean. It was wonderful and enlightening. Wish there was a magic pill for it.
Yes, yeah. We'll keep working on it.